Bismillahirrahmanirrahim. My name is Dr.Saeeda Bano. I am Associate Professor of Obstetrics and Gynecology at Sahiwal Medical College, Sahiwal. Today's lecture is for final year MBBS and the topic is Endometrial Carcinoma. I will start my lecture with one case history. This is a 65 years old woman who presents to the gynecology clinic with postmenopausal bleeding. She is obese and suffers from type 2 diabetes. She has no children, has never taken hormone replacement therapy and does not smoke. Her cervical smear have always been normal. Now, from this case scenario, you can get different short answer questions in your written and in your auspice, like what is the most likely diagnosis in this case, and how will you investigate this patient, and how will you treat this patient. So at the end of the lecture, I will show you different questions and also single best questions related to this presentation. Endometrial carcinoma, I will discuss today introduction, risk factors, protective factors regarding endometrial carcinoma. How are you going to classify endometrial carcinoma? What is the spread, and what's the clinical presentation? How are we going to investigate for a case, suspected case of endometrial carcinoma? How it is staged, and what is grading important in endometrial carcinoma, and what's the treatment? Endometrial carcinoma, as the name indicates, it is the carcinoma of the endometrial glands of the uterus. It is the most common gynecological malignancy in postmenopausal ladies. And this is most common malignancy in women after breast, bowel and lungs. Majority of endometrial carcinomas are adenocarcinomas. This is the gross appearance of endometrial carcinoma on a hysterectomy specimen when we open it after doing hysterectomy. Uterine body is called uterine corpus, and uterine corpus cancers are of two types. One from lining of the endometrium, that is endometrial carcinoma, and the other one from stroma. This is called sarcoma. Sarcomas are relatively rare. So this most common gynecological malignancy, this is the 8th leading site of cancer-related mortality, and lifetime risk of developing endometrial cancer is approximately 1 in 46. The mean age of diagnosis is 62 years, although these cancers, 25% of the ladies in the reproductive age group, like in the premenopausal period, they can have endometrial carcinoma as well, who present with abnormal vaginal bleeding. The incidence of endometrial cancer has risen steadily over the past 20 years as a consequence of the aging population, the trend away from hysterectomy for benign causes, and the obesity epidemic. Now, what are the risk factors for endometrial carcinoma? Any agent or factor that rises the level or time of exposure to the estrogen is a risk factor for endometrial carcinoma. Estrogen causes proliferation of the uterine endometrium. So, if the exposure is excessive, either by amount or time, then there are more chances of having endometrial hyperplasia or endometrial carcinoma. Now, the risk factors: older age, early menarche, late menopause, more time of estrogen exposure, nulliparity, so more cycles, because pregnancy has a protective effect and there is no ovulation during the 9 months, so it's a protective. But nulliparity, there is no such protection. Then unopposed estrogen like obesity, polycystic ovarian syndrome and hormone replacement therapy. Then chronic tamoxifen use, How tamoxifen leads to endometrial carcinoma? Actually, tamoxifen, as it is known, that is a drug we use after treatment of breast cancer, after breast surgery. This is used. This is a partial estrogen antagonist and agonist. So on the breast tissue, this is estrogen antagonist. On the endometrium, uterine endometrium, it is agonist. So it leads to endometrial hyperplasia and then carcinoma. Then other factors are previous pelvic irradiation, hypertension and colitis, estrogen replacement therapy and endometrial cancer. As the dose and exposure increases, there is dramatic increase in the risk of endometrial cancer development. As you can see, after 10 years of use, the relative risk is more. Then tamoxifen use and placebo. As we can see that endometrial cancer risk is increased after tamoxifen use. Now, history of other estrogen-dependent neoplasms like breast and ovary, family history of endometrial carcinoma, then estrogen-secreting ovarian cancer, for example, granulosa cell tumors, and family history of endometrial carcinoma is important. There is one condition which is called hereditary non-polyposis colorectal cancer syndrome or Lynch 2 syndrome, in which there is history of colorectal and there is history of colorectal cancer or other GI cancers, ovarian and urothelial tumors, depending upon the mutation responsible. All these type of risk factors, they are for type 1 endometrial cancer. The risk factors for type 2 endometrial cancers are less well understood. I'll discuss later different types of endometrial cancers. Now, risk factors, there is one mnemonic: cold nut, C for cancer, ovarian, breast, colon, O for obesity, late menopause, D diabetes, nulliparity, unopposed estrogen, and T for tamoxifen. So when we evaluate a case, we can use this mnemonic, or we can ask all these different types of we can evaluate all these type of risk factors in the history of the patient suspecting endometrial carcinoma. Now, there are certain protective factors. Any agent or factor that lowers the level or time of exposure to estrogen is a protective factor against endometrial carcinoma, like hysterectomy. When there is no uterus, of course, there is no chance of getting endometrial carcinoma. Then combined oral contraceptive pills, progesterone-based contraception, including injections, then intrauterine device including copper IUCD or progesterone containing intrauterine system like Mirena. Then pregnancy is a protective factor against endometrial carcinoma, and smoking. This is a chart showing OCP used and relative reduced risk of endometrial cancer by years of use. There are two types of endometrial cancers, type 1 and type 2. Type 1 endometrial cancers, they are usually endometrioid endometrial cancers and also mucinous subtypes. They have favorable prognosis, and usually this type of cancers, they arise from a hyperplastic endometrial background. Type 2 type 2 endometrial cancers, they include high grade serous and clear cell histological subtypes, and they arise from an atrophic endometrium. They are aggressive and they have usually poor this is the pathological terminology which we use in endometrial cancer. Types 1 and 2, as already I have described. Type 1 cancers, usually 75 to 80% are endometrioid adenocarcinomas which have favorable prognosis. Type 2 cancers, high-grade serous and clear cell, they carry a worse prognosis. And then endometrial carcinomas, they are also graded, type 1, 1 to 3, with 3 being high grade. These are mostly abnormal cells, well differentiated, moderately differentiated, and poorly differentiated. Then FIGO staging is used for spread and size of the tumor. Stage is used with type and grade to give prognostic information. So when we get histopathology report from a pathologist, he tells us this is stage 1, 2, 3, type 1 or 2, and then also histopathologist mentions the grade as well. So same endometrioid, adenosquamous, papillaceous clear cell carcinomas. One is adenosquamous as well. They are 15% of the cases. You must have read all this in your pathology books. Now the spread of the tumor. One is direct extension to the myometrium and to the cervix. Then there is lymphatic spread. Then also it spreads through the fallopian tubes, and the other spread is hematogenous to the lungs. This picture also shows the spread of the tumor. So you can see it spreads to the cervix, it spreads to the myometrium. Also there are vaginal mats, then lateral pelvic glands, then ovarian mats, then internal iliac and para. How does it present? Patient profile. Usually most of the ladies, as this is the disease is of postmenopausal women, so most of the ladies, they present with postmenopausal bleeding. Postmenopausal bleeding is a red flag symptom for gynecological cancer, and it should always be taken very seriously. Other thing is nulliparity. History of early menarche, late menopause, and then obese patient, then history of hypertension and diabetes. These are all risk factors which we have to ask from a patient while we are suspecting endometrial carcinoma. Or all these patients having this type of history, we should suspect a possibility of endometrial carcinoma. Less than 5% of the women, they can be asymptomatic. Abnormal bleeding is one of the presentation, like I have mentioned that postmenopausal bleeding, but it could be menorrhagia in the premenopausal ladies, or postcoital spotting, or intermenstrual bleeding. Blood-stained vaginal discharge is another presentation. If there is cervical stenosis, like the postmenopausal ladies, they might come to you in outpatient department with blood-stained vaginal discharge, or they might present with purulent discharge. So there could be pyometra or hematometra. As in menopausal ladies, there is cervical stenosis because of atrophic cervix. So there could be collection of the blood in the uterine cavity, or it once it get infected, then there is pyometra, or there could be colicky abdominal pain. So all these symptoms, they should be taken very seriously, especially in postmenopausal ladies. Postmenopausal bleeding is endometrial cancer until proven otherwise. 90% of the patients with endometrial carcinoma, they present with postmenopausal bleeding. Although not all postmenopausal bleeding patients, they have underlying endometrial carcinoma. Only 5 to 10% of women with postmenopausal bleeding, they have an underlying gynecological malignancy. But we have to take this 5 to 10% very seriously. Now the signs examination. Is patient pale? what is the BMI of the patient, lymph nodes enlarged, then pelvic abdominal examination and pelvic examination. Speculum examination, cervix might be normal looking, there might be blood or purulent discharge through the cervical os, and on bimanual examination, uterus either atrophic, normal or enlarged. Usually uterus is mobile unless in late stages when there is local spread. Parectal examination is always not required unless there is parectal bleeding or we are suspecting advanced stage. Then regional lymph nodes, they should always be examined, and then breast examination is important. Majority of the patients, they are diagnosed early when surgery alone may be adequate for cure. Usually diagnosis is by history and physical examination. Then we can have uh, complete blood count for assessment of hemoglobin status of the patient. Then diagnosis and investigations of the postmenopausal bleeding, or in a case suspecting endometrial carcinoma, transvaginal ultrasound is of utmost important. Transvaginal ultrasound, it tells us about the endometrial thickness. If endometrium is more than 4 mm, then we should have endometrial biopsy. If it is less than 4 mm, then endometrial carcinoma is very less likely. And other investigative measures, they are hysteroscopy and endometrial biopsy. And hysteroscopy and endometrial biopsy is gold standard for evaluation of endometrial carcinoma and for the evaluation of postmenopausal bleeding. Hysteroscopy performed, okay, we'll discuss later. Hysteroscopy, no. Transvaginal ultrasound, as already mentioned, findings suggestive of endometrial carcinoma could be endometrial thickness if more than 5 mm, hyperechogenic endometrium with irregular outline, then increased vascularity, and also if there is intrauterine fluid, it is suggestive of endometrial carcinoma. Here, this is the way we perform an transvaginal ultrasound. This is the transvaginal probe. Here we can see the longitudinal view of the uterus. This is endometrium, which is very thin, and this is the myometrial echo texture. Here endometrium is thick. So in these type of cases we must have endometrial. Now, hysteroscopic guided endometrial biopsy is the gold standard. This is a hysteroscope which we introduce through the cervix into the endometrial cavity, and there is a camera attached to it, and we can visualize the abnormal areas inside the uterine cavity, and then we can have hysteroscopically directed endometrial sampling. Pap smear is not diagnostic, but a finding of abnormal glandular cells of unknown significance leads to further investigation. Abnormal pap smear is the presentation of 1 to 5% of endometrial carcinoma cases. Pap smear and endocervical curettage is required to evaluate cervical involvement. This is old actually. In the olden times when we used to do endometrial sampling, it was called fractional curettage. We used to take biopsies from all walls and then endocervix, but no, because of the availability of the hysteroscopy, it is not that. Pre-op evaluation includes physical examination, blood tests, complete blood count, and all liver function tests, renal function tests, ECG, chest X-ray, pelvic ultrasound. Staging of the endometrial carcinoma. The extent of disease is determined by MRI scan, MRI of the pelvis, because it would tell us local spread of the tumor. involvement of the myometrium, involvement of the cervix, involvement of the parametrium and paracervical areas and the paravaginal area. Patients with high-grade tumors, they undergo CT scan of the chest, abdomen and pelvis to exclude distant metastasis. Women with early stage 1A, 1B endometrioid adenocarcinoma are offered surgery at their local hospital. So this is also one of the benefit of having MRI scan. Women with high grade or high stage tumors, they require surgery in a cancer center, as this has been shown to improve the outcome. So high grade we can find out from endometrial sampling and high stage from MRI pelvis. This is FIGO staging for endometrial carcinoma. Stage 1, tumor is limited to the uterus. 1A, less than half of the myometrium, and 1B, more than half of the myometrium. Stage 2, extension to the cervix. Stage 3, spreads through adjacent structures to the uterus. 3A, invade serosa or adnexa or positive cytology. 3B, vaginal invasion. 3C, invasion of pelvic or para-aortic lymph nodes. And stage 4, spread further from the uterus. 4A, involve bladder or rectum. 4B, distant. This is the pictorial evidence of endometrial cancer staging. You can see one, this is stage 1. Here it is limited to the uterus. Then B, involving the cervix. Then 3, it is in the pelvis or upper vagina. Then 4, 4A to bladder or rectum mucosa, and then 4B. Here this is what it on the examination PR exam was mentioned to exclude this disease, this extent, and also this much we can see on MRI pelvis for staging. So now you can get the idea that MRI pelvis is of very much important, has great importance, because it can tell us the extent of the disease, the extent of spread in the pelvis. Well differentiated, patchy differentiation, and then poorly differentiated. Higher the grade, worse the prognosis. Then what should be the treatment of endometrial carcinoma? Surgery, chemotherapy, radiotherapy, hormone therapy. We'll discuss one. Surgery is the mainstay of the treatment for endometrial cancer. The extent of surgery depends upon several factors, including grade and stage of the disease and the patient's comorbidities. Standard surgery is total abdominal hysterectomy and removal of the both fallopian tubes and ovaries, bilateral salpingo-oophorectomy. So THBSO. This is old. Pelvic washings, periaortic node dissection, not recommended. For stage 1, this is total abdominal hysterectomy and bilateral salpingo-oophorectomy. For stage 2, it should be radical hysterectomy. Surgery is the mainstay of the treatment. The mentioned standard is to THBSO. If MRI suggests cervical involvement, that is stage 2, then a modified radical hysterectomy is performed, which also removes cuff of vagina, paracervical and parametrial tissues to ensure adequate excision margins. If the tumor is of high grade or type 2 histology, dissection of pelvic or para-aortic lymph nodes, it remains contentious. There was one trial, Aztec trial in UK. It was the role of lymph node dissection in endometrial carcinoma. It remains contentious because the study failed to show a survival benefit for dissection. Critics of the study argue that it was underpowered to show survival benefit in those at high risk of the nodal disease. Then adjuvant therapy. Post-operative radiotherapy reduces local recurrence, but it does not improve survival. Brachytherapy is used for local disease. Brachytherapy is the one, brachy means slow therapy. Here, intravaginal therapy, where the cesium needles or radium needles, they are inserted inside vagina, and this radiation therapy locally locally abolishes the disease. Brachytherapy plus external beam radiotherapy for locally advanced disease. Chemotherapy is given for advanced static disease. There is also one option which is called hormone therapy. This is for who are not fit for surgery. Others wish to avoid it for fertility sparing reasons. Like premenopausal ladies, treatment with high dose oral or intrauterine progestins is successful for some women with complex atypical hyperplasia and low grade stage 1A endometrial tumors, but relapse rates are high. So a hysterectomy removes the uterus and may also remove the cervix. Total abdominal hysterectomy, here it removes the uterus, and then removal of the ovaries and tubes. This is what we do in endometrial carcinoma. And in radical hysterectomy, the paracervical tissue and cuff of vagina is also removed in case of endometrial carcinoma if it involves the cervix. Radical hysterectomy is the treatment option for early stage cervical cancers, and also if endometrial cancer involves case of thorough physical examination after total abdominal hysterectomy and bilateral salpingo-oophorectomy, or if radiotherapy is required and patient comes for follow-up. Thorough physical examination, chest x-ray, regular CA1 to 5 estimation, mammography, CT, MRI when it is indicated. If examination is normal, then no need. In the first 2 years, every 4 monthly, then 6 monthly, there are prognosis for distant metastasis. Prognosis for stage 1, this is 88% 5-year survival rate. For stage 2, 75%. Stage 3, it is less, 55%. And stage 4, this is screening. There is currently no evidence to support screening for endometrial cancer in high risk groups or in the general population. References: there is no effective screen. Now, endometrial cancer and fertility. So 25% of the ladies who develop endometrial carcinoma in their reproductive age group, usually they have underlying history of infertility. Primary infertility due to polycystic ovarian syndrome is a risk factor for premenopausal endometrial cancer. So there are two devastating diagnoses at one time. One is infertility and the other one endometrial carcinoma. Now they have to sacrifice their uteruses. So alternative to hysterectomy is only for pre-cancer or early stage low grade endometrial cancers. Hormone therapy, either oral progesterone or levonorgestrel intrauterine system, is associated with moderate response, but it has got high relapse rate. So ovarian conservation, endostimulation for egg retrieval and surrogacy is also an option in these type of patients. Now we will come to our case history. She is a 65 years old lady who presents with postmenopausal bleeding. She is obese, she has diabetes, no children, no HRT use, does not smoke, cervical smear was always normal. So what is most likely diagnosis, and then what are the key points in the examination and investigations which would favor endometrial carcinoma? Or in other words, how are you going to examine this lady? What are the points in examination, and how are you going to investigate this patient? And then how would you manage her? All these questions you will write down in your notebooks, and you will deposit your assignments at the end of vacation. So this is your homework for today's lecture. Single best answer questions. A 54 years old woman attends the gynecology department with postmenopausal bleeding. A transvaginal ultrasound measures her endometrial thickness as 8 mm. Endometrial biopsy is taken, and endometrial biopsy report shows moderately differentiated endometrial adenocarcinoma cells. Then, what is the most appropriate staging investigation? Choose the single best answer. You have to answer all these options, and you have to justify why chest x-ray is needed or not needed, CT scan of her thorax, abdomen and pelvis, why or why not, hysteroscopy, why or why not, MRI scan of the pelvis, why or why not, then transabdominal ultrasound scan. So read please carefully. Biopsy has already been there, the result of biopsy has already been there, and then now you have to stage her disease. So what is the most appropriate investigation? Then the other question is, this is also single best. A fit 72 years old woman has an MRI after endometrial biopsy shows endometrioid adenocarcinoma of the endometrium. Endometrial biopsy shows endometrioid adenocarcinoma. Then she had MRI of the pelvis, and staging from the MRI is stage 2. What management is indicated? Use the single best answer. Why or why not you will choose this option? You have to write A. Carboplatin based chemotherapy, B. THN BSO, C. External beam radiotherapy to the pelvis, D. Modified radical hysterectomy, then E is brachytherapy. Please write down answers of all these questions and deposit your assignments after coming back from vacations.